I think it's about time to begin Symposium 10. It's my pleasure to welcome you to this symposium. I'm Dr. Sugahara, a practitioner for my own private clinic here in Fukuoka, Japan. I had been a senior staff of Department of Psychosomatic Medicine of Kyushu University Hospital. Now, I'm a psychiatrist and a primary care physician. My specialty is psychopharmacology and mood disorder. Our first presentation of this session is to be given by Dr. Andri Andri. Dr. Andri, please. Dr. Andri is a psychiatrist with special interest in psychosomatic medicine and consultation liaison psychiatry. He earned his medical doctorate from University of Indonesia, where he also had his training in psychiatry. He is the chief of psychosomatic clinic, Omni Hospital, and a member of faculty in psychiatric division, Faculty of Medicine, Kurinda Wakana Christian University. He is a member of section Psychiatry in Education, World Psychiatric Association, WPA. He was a member of International Advisory Board of World Congress of Psychosomatic Medicine, August 2015 in Glasgow. Dr. Andri is a writer in national newspaper, a blogger, a public speaker, media-based friend, and also a fan of social media. He has 3 non-fiction books and has publications related to psychosomatic medicine, psychiatry, and mental health. The first paper is entitled Somatic Complaints in Depression and Anxiety Disorder Patient. Dr. Andri, please.
Thank you very much, Professor Sugahara. Ladies and gentlemen, it was a pleasure to come to this lovely meeting, and would like to present about the somatic complaints in depressions and anxiety disorder patients. As we know that depressions and anxiety is increasing in the global populations now, and the number of people with depressions and anxiety is increasing from 1990 by 460 million to 650 million in 2013. And it was close to the 10% of the world's populations is affected with this kind of mental disorders. And if we talk about depressions, that the fact is a very common mental disorders. It is estimated by WHO in 2020, it will become the second global burden of public health in the world. And we say that the more women are affected by depression than men, and it's worse, depressions can lead to suicide. But fortunately, this is an effective treatment for depressions, and we know that we struggle for that, and in our clinical practice, we give the patients treatments related to depressions, and also how to maintain the preventions of relapse and maintain the remissions of the patient. We talk about the economic problems related to depressions, and it was said that every dollars invested in scaling up treatment for depressions and anxiety leads to returns of $4 in better health and ability to work. But the problem is, in our clinical practice, I am a psychiatrist. We know that the symptoms of depressions, most of us rely on the psychological symptoms, like sadness, loss of interest, overwhelming sad, anxiety, or excessive or inappropriate guilt. But sometimes we forget that there is also a physical symptoms, such as headache, pains, fatigue, or even related to weight gain or loss gain. So these kind of things that we in our clinical practice often forget about how to get the ideas to talk to the patients and ask specific questions about the physical symptoms, not only the emotional symptoms of depression. WHO in one of the report conducted in one of the journal in 1919 said that the 2/3 of the patients presented their depressive mood with somatic symptoms exclusively. So the people come to the physician, the primary physicians or the specialists with the symptoms of somatic problems, but the basics of the somatic problems is conclusively as a depression. And more than half complain of multiple medically unexplained somatic complaint or somatic symptoms. From this report, we know that symptoms of depressed patients attending primary care physicians come to the 96% of physical symptoms are reported. And it's very common to say that in the primary care, the complaint of the patients is back pain, neck tension, headache, neuralgia, even the specific like palpitations, stomach problems, dizziness, and drowsiness. And it was sometimes mixed up with other specialists, like specialists in internal medicines and also neurologists, when the patients come with these specific symptoms. I believe that most of the patients will not come to the psychiatrist in the first hand, but will come to the physicians in primary care or even the internal medicine as specialists in neurologies or in internal medicines. And in this slide also, it was said that the chest pain, fatigue, dizziness, headaches is one of the problems that related to the somatic symptoms of depression. And it was said that an organic cause of pain was found in only 60% of cases. So the other causes is unknown or medically unexplained, we said in the past. Many patients with depressive symptoms related to the chronic painful symptoms are very high prevalence in the subject of depressive symptom patients. The problem with the chronic painful symptoms, not only just one symptoms, but also more than one. And it was said that when we talk about the problems related to the symptoms of pain and also related to the problems, more than two pains in the depression, the remissions may be affected. So the improvement in painful physical symptom is associated with the increased remission rate. We know as a clinician, we want to get the patients have a better quality of life, have the remissions, and also the preventions of relapse of the depression. And when we fail to achieve the remissions in link with the patients of depression, it will be linked to relapse of the patients. So when the patient has no remissions, when we say that we use the Hamilton Depression Rating Scale, and then it was said that if we have very little chance to get remission in patients with depressions and also linked to relapse. The problem is in our clinical practice, I am a psychiatrist. When we diagnose these patients with depressions, we use DSM-5 or maybe ICD-10. The problem is our standard diagnosis criteria does not stress and focus on physical symptoms of depression. We see the DSM criteria for major depressive disorders. The problems related to the somatics only loss of energy or fatigue, worthlessness or guilt. It is a very emotional problem, change in weight and appetite, and also maybe kind of like a insomnia or difficulty in sleeping. Dr. Farfa said conventional scales for depression used in clinical trials rarely included significant data on somatic symptoms. The inventory that we use very frequent in our clinical practice is a back depression inventory. And if we carefully see this inventory also, there's only 4 related to the somatic symptoms of depressions. It is a loss of energy, changes in sleeping pattern, changes in appetite, and tiredness or fatigue. The problem is when we see the physical symptoms of, as a predictors of depression, more patients with physical symptoms will have more chance to have a depressive symptoms. So it was said in the previous study that patients has more than 5 symptoms of pain or physical symptoms will have a chance to get more than 40% of the depressive symptoms or diagnosis as a depression. When we look at the problem with mood disorder and with anxiety disorders, comparisons between the symptom presence and the symptoms absence in the patients with depressions or anxiety, the symptoms of physical symptoms like headache, chest pain, abdominal pain, and also the back pain is rather has a high percentage in the patients with mood disorders and anxiety rather in the symptom absence of physical symptoms. We know that sometimes we related the depressive symptoms and anxiety problems and somatic symptoms with the diagnosis of somatoform disorder, or in DSM-5 we know as a somatic symptoms disorder. And it was said that at least a third of patients with somatoform disorders have comorbid anxiety or depressive disorders. So come to the mind, I think it will be a great idea to get knowledge and also a good perceptions about what is the specific physical symptoms of the patients with depression and anxiety. So I have a survey. It was done 1 year, and then there were about 11,000 respondents who joined the survey. They had been diagnosed as depressions or anxiety disorder. It was an internet-based survey using surveymonkey.com, and most of the respondents, 57% are women and 42% were men. We used Bradford Somatic Inventory to define specific somatic complaints. It's a very rare inventory that we use in clinical practice because it only, get the specific symptoms. There are 46 questions related to physical symptoms, only physical symptoms in depression and anxiety. We know that the BSI was first published on the article in the British Journal of Psychiatry in April 1991 by David Bartwell Mumford from University of Bristol. I'm sorry if you cannot see this inventory clearly, but you can get it in internet. It's free to download, or maybe you can contact Dr. David to come to this Bradford Somatic Inventory. So from the survey that we conducted, there is a top 10 somatic complaints about the depression and anxiety patients, and they complain about these specific 10 somatic complaints. The first, the most somatic complaints that the patients say it was palpitations, lack of energy, and pain. The other is aches in the abdomen, feeling giddy, feeling tired, excessive wind or belching, hearing buzzing noise in ears, sometimes like a tinnitus-like syndrome, trembling or shaking, and mouth or throat felt dry. From the specific of this graphic, we know that It's a very common to see the patients with somatic complaints. It's a depressions and anxiety patients, but also complain so many things about somatic complaints. They complain about more than 10 somatic complaints when they diagnose as depressions and or anxiety. So the discussions of this survey is our results similar with previous study about the relationship of somatic complaints and psychiatric disorders. The previous study said that in the 40s, 430 patients with the diagnosis of major depressions, two-thirds complain of general aches and pains. Somatic complaints in depressions, lack of energy, sleep disturbance, general aches and pain also reported in the previous study conducted by Dr. Tyler and friends. So I think the take-home message for my presentations is we as physicians must aware that somatic complaints sometimes cover the psychological symptoms of depression and anxiety disorder. We know from the study that patients, especially the elderly patients, mostly come to the psychiatric problem or to the physician as a pain complaint, not as a kind of a psychological complaint. And when we talk about the complaint, the specific complaints that delivered by the patients to the physicians in the clinic is palpitations, lack of energy and pain are among the most prevalent of somatic symptoms in depression and anxiety disorders. Maybe it can be different. I held a survey in Indonesia, but most of the studies related to the somatic complaint said that pain and also the fatigue is the most prevalent somatic symptoms of depressions and anxiety. And I think when we are treating somatic symptoms in depressions and anxiety disorders very well, we can also prevent relapse. Because if we are not aware of this, we are going to lose the patients. Maybe this is actually problems with some psychological or psychiatric problems, but because patients came to us as a somatic complaint, and we are going to lose these patients and cannot treat him well. So I think this is the end of my presentations, and I hope you have benefits from my presentation. Thank you very much. Arigatou gozaimasu.
Thank you, Dr. Andrew. The floor is now open for discussion. I'd like to ask you a lively discussion, please. For those of you who want to raise questions, please make sure that the microphone is on before you talk and give your names and affiliations when you start your question.
Thank you very much, Dr. Andrea Lee from Indonesia. My name is Hiroshi Shizu, Emeritus Professor of University of the Ryukyus, Okinawa, Japan, one of the Vice President of the Asian College of Psychosomatic Medicine. Depression patients also associate sexual dysfunction frequently in my clinic. So I will ask you, how do you think about sexual dysfunction associated in your clinic?
Thank you for the sexual dysfunctions of the patients with depressions were also in the survey. When we talk about the survey, and this is the questions about related to the problems of depressions and also the sexual functions. Have you had difficulty getting full erection, or have you felt that you have been passing semen in your urine? It's sometimes related to the patients of men. And in our clinical practice, patients specifically come to the clinic or to come to me having a complaint of sexual dysfunctions are not very common. They sometimes complaints of sexual problems is related to the libido or to the desires of the sex. So it was said that sometimes they complain more about fatigue, or maybe because sex is not very common to talk about in a clinical. Maybe they ashamed of that, or maybe it is very private section. And then in the first hand, sometimes in the first interview, even I asked about the sexual problems. Sometimes they very reluctant to say openly in the first interview.
Thank you very much. Sexual dysfunction is very secret, so not frequently open. So, however, survey or sexual dysfunction will be recovered the depression and anxiety. It is very interesting.
Yes, I very agree with that. Thank you, Professor.
Are there any questions? Yes, please.
Shooting response. I please so I always use some SDS score, and if the beauty point is over, we use some lines. So how do they correlate the SDS score? Very severe or not?
I beg your pardon?
SDS score.
Somatic depression and scale? Somatic depression scale, yeah. I rarely use it in the clinic. There's a depression anxiety somatic scale in one of the studies, but talking about DAS or the depression and anxiety scale, it's also it also consists of specific psychological problems, and also the SDS also. Why I choose Bradford Somatic Inventory? Because it's very specific, asking about the somatic problems, not only the psychological problem. So the patients who follow the study or follow the respondents of the study is he had or she had to be diagnosed as depression or anxiety first, and then we ask more about the somatic complaints. So I think it's a good idea also to take the SDS in the next studies. Thank you so much, Professor.
Okay. So please.
Thank you for your wonderful presentation. I'm Yoshinobu Matsuda from Kinki Chuo Medical Center, Osaka, Japan. Let me ask you one question. How did you choose the participants? So all participants had depression and anxiety.
Yes, this is one of the limitations of the studies, because we ask the patients only if they are already diagnosed. And this is what we said in the presentation. This is the internet survey base. So I think what I'm going to looking for in the first hand is about the kind of like the opportunities about either they understand about the somatic complaints of depression. So this is not a clinical based survey. This is an internet based survey. So we ask the patient. Actually, they put it in the internet, the surveymonkey.com, and when the patient seems that I'm one of the criteria is meet with me, and then I will choose to fill the questions in the survey. But surprisingly, I'm very surprised about this. The result is it's also comparing to the other previous study with the sophisticated statistical analysis, it's quite rather the same. You know, kind of like most of the patients complain about edges, about pains, about palpitations, and also about fatigue. And previous studies said that the three kind of somatic complaints, edges, pains, and also the fatigue, is the most prevalent somatic complaints. And it is compared to my limited survey, it's a very still have correlations about that. And I think in the future we have to be more sophisticated analytic and statistic analysis.
So you use that data of patients with depression or anxiety?
Yes, we kind of like mix up, not specifically this is the depressions or this is anxiety, because the Bradford Somatic Inventory also said that this is not specific for depression. It is also can be used in anxiety patients with somatic complaint.
Thank you so much.
Thank you so much, Professor.
Any other question? So I have concerning to the internet survey monkey, were there any merit for the responders? For example, a kind of token or a coupon or a promise to inform the result of the study if they want to know. Are there any merit for the responders to join?
Yes, of course. That it was said that in the survey they are agreed that the survey is will be published in one of the symposiums related to the psychosomatic problems.
I mean, are there any gain for the responders?
No. They
Voluntary.
yes, they voluntarily fill the questions in the survey.
Okay. Thank you.
Thank you very much for this.
So let's move on to the next speaker. Thank you, Dr.
Thank you.
Allen.
Thank you very much.